You identified obviously as acute and chronic patients in your subset.
Yes.
Did you notice any differences between the levels of abnormality with the proteins that you found, or between the two lots? Or?
Not specifically, no. And it might be something we see with a larger patient group that might become more clear, but just with our small subset, it's hard to really tease out those maybe very subtle differences between the two groups. So, yeah. Not yet. We can replicate it.
My feeling now is that sort of how I look at ME is that there's an initial agent that causes either a group effect, like we have seen with the Royal Free and Inclined Village and Tapanui, whatever that agent might be. It might be a virus or some other thing. And then there are a lot of sporadic cases, which could be a surgery, or it could be, I've got someone in our studies at the moment who's suffered from several years of child abuse, and so what has amazed me in actually dealing with individuals, and Ros can, I think, talk to this, is that when they talk about their disease now, it seems the same, even though the origins were different. And it's almost like there's a body response to this initial trauma, whether it be viral infection or whatever, and the body is sort of set, I think, via the brain to a new homeostatic kind of level. And that's what I think now is ME/CFS, And so remarkably, your question is a very good one, because we've considered that. Initially, we just got a cohort of ME people, and a couple were acute and the others were chronic. And we've thought about, taking young women in the sort of the critical age, say, 20 to 35, and get them in the acute phase and study them and see if they're any different. And yet, the Stanford study in 2016, when they looked at the metabolome, they just seemed to select about 45 patients. They didn't worry how they were really diagnosed properly or whatever and what stage. And yet, they got very clear evidence that they all seem to have the same thing going on. In other words, that once you go into that homeostatic state, maybe that's kind of where everyone comes alike, as it were, and also whether it's chronic or that it stays like that state. And so the critical thing is, how do you switch people out of that state? Okay?
Yeah, I would say that probably it's purely guesswork, but probably 80% of my patients will have started with an infection, but there will be 20 to 25% who might have started with a surgical operation or an accident or some sort of mental trauma, major trauma, maybe an immunization sometimes. So there are all sorts of different ways that the trigger seems to trigger it off. So there perhaps is something in their genes that makes them very prone to this the moment something goes wrong with the body.
I mean, you mentioned the predisposition, and I do wonder, I've got two kids with it, so they had whooping cough at a young age and then lived normal lives until both getting glandular fever and now 3 years of CFS. So, you mentioned that predisposition as to whether maybe there is something underlying prior to the initial trauma to trigger it.
Yeah, genetic predisposition, just like there is to a number. Probably if we moved on 50 years, we'd find there's a genetic predisposition to almost every disease that we get,
There's just been an article published in Human Genetics on the genetics of CFS. I came across it last week, just been published, and so I was quite excited to go through this. And when I actually got to the end, I thought, there's really nothing here at the moment that's informing us, unfortunately. So there are some genetic studies that have been done, but nothing really is kind of, jumped out at you as it's this or that, or, group of genes or whatever. Unfortunately, one hopes that the genetic predisposition will come about, because like in my daughter's case, pretty well her whole class of 13-year-olds at Logan Park got glandular fever, and she came down with ME/CFS, and so we know, what is it, about 10% of people who get glandular fever will come down with the disease, the other 90% don't. So that's what we think, at least that's what I think is the genetic predisposition.
And it may be the same that they'll come up with the COVID thing, the so-called long haul thing. It may be people have got some sort of genetic abnormality that makes them prone to becoming that way.
Yes.
I heard that the COVID thing had a blood group type. Is that correct? And is it likely to be the case with ME?
It's it is that if you're old and you're a male and you've got A group, and that's me, with all three, then you are more susceptible for having a more serious illness from COVID infection. So there seems to be a blood group effect, and that's on the initial illness,
But these people I have who have had post-COVID, admittedly we've only had 3, and I won't get many in New Zealand because we haven't had very many people with it, but they've all been young women. They haven't been that, and their illness, their COVID illness was quite mild, all of them.
And do you know their blood type?
I wouldn't have a clue. No.
Because I'm a blood type, so maybe it's similar to, maybe it predisposes you to ME too.
Yeah, I think that I would separate the ME or even the long haul a bit from how ill they are in the initial infection. And as Ros says, it isn't necessarily the people that are really very ill and are recovering who are all the long haulers. It's actually people that get some quite mild infections, but they're still,
It does something. And the same with, all the many people I've seen with glandular fever as being the trigger. Many of them, the illness has been really mild. They've hardly been aware of maybe a mild flu-like illness, and the doctor happens to have done a glandular fever test around that time and found that they are suffering from that. But often it's very, very mild. Doesn't have to be a severe illness.
Yeah, and I think our scientific understanding of genetics and the genome and how that itself is regulated is still, we're still learning and coming up with new discoveries. Like DNA methylation is a very recent kind of field of scientific research. So as our understanding grows about genetics and how that is regulating things, maybe we might find something a little more subtle than this particular gene that gives you susceptibility. So we're still
Open the door for gene editing and going down that pathway for some longer term.
I think about probably 10 years ago, Jonathan Kerr, who's a genetics person from London, he found that there, quite a small number he looked at, but he found there were 8 different subtypes of genes that seemed to be associated with people who got ME, and that they sort of, each of these gene subsets related to the particular symptoms that the patients ended up with. So there were a different group who had a lot of bowel and stomach symptoms, and another group who had maybe neurological symptoms, and so on.
It's complicated now. Genetics is complicated because, as Eiren, not only do we have just our stable genetic code, we have our epigenetic code, and we've just had a paper accepted in clinical epigenetics. We've looked at these epigenetic changes occurring and asked, can you see them in ME people, differences, and we found some quite dramatic changes, and you can relate some of those changes to affecting genes which can explain some of the symptomology, certainly affecting things in the brain as well as in metabolism. So you're getting a small window into it now, but it's just, and it's tantalizing, but it's so difficult to see the big picture.
I think the good news too is there are some really good scientists around now, like these people, for example, but also all around the world who are working on this illness. Whereas, back in 1980, when the ME Society first started, there was hardly any research going on.
I'd like to ask a question around B12 injections, because it took a long time before they, agreed that they worked. And I used them monthly for a while, and I'm using them 3 weekly. I have used them 2 weekly when under stress, shall we say. But there's always been a discussion whether you can have too much of it and might have to stop, so I've been reluctant to go to 2 weeks continuously, but I don't know what the state of research is.
The research goes way back to Icelandic disease, actually. And they, way back in the early times, were, finding that B12 injections were helping people. And then that research has been sort of every now and again re-emerged, and some of the Iceland people have been continuing with that research. But in practical terms, what I find is most people's B12 level is perfectly normal when you measure it in the blood. Some of the research in America shows that the B12 level in the fluids surrounding the brain is actually quite low, lower than it should be. Which gives us, that coupled with some of the Icelandic research, gives us a sort of feeling that yes, we should have a go if it's a safe thing. I've had patients, probably like yourself, who've had it long term, fairly often. I very rarely, if ever, have seen anyone with any unpleasant side effects. Occasionally, the first injection, the odd little blip of allergy reaction around the site of the injection, but very rarely have I seen anyone who said, that injection did something terrible to me. So it does seem very, very safe, and it has been around for a very long time. And a number of people, a very large number of people, will do quite well on it. It doesn't cure the illness, but they feel better when they're on it. And Nancy Clemens' group have said, yes, if you're going to use B12, and they've had some researchers there who've looked at it too, including someone called Dr. Death, which I think is a very unfortunate name. But he had shown that, again, there were some good reasons to try it, a little bit more scientific. Here's a